Good morning, everybody. My name is Kristin Davis, and this is Isa Krzos. We are with Threshold's Evaluation Department, and I think by way of introduction, really the best thing to say is that we are not, I think, like everyone else, part of a county department of public health. We are with a provider organization called Thresholds, who, and I'll tell you a little bit more about us, but basically we provide behavioral health care services. And we, I think, are a nice partner because we're maybe just one level down. It's a little bit more nuts and bolts, I think, from the first presentation, which was really great, by the way. Okay. So our plan today is to do two things. One is to talk about this year-long process that we went through to share data with our primary care partners. And two, to talk about our plans to use that data that we now have shared. And like the speakers that came before us, we're really focusing this first year on our highest of the high need patients. Threshold serves people who have very high needs. We're going to select those with the highest needs as defined by, just as you all were talking about, those folks who are high users of unnecessary inpatient services, whether that be hospitals, ERs, it's also often shelters, criminal justice system, and so on. Before we go into that, though, let me tell you about Thresholds. We broadly just provide mental health services and address social determinants, relying on a high-intensity, high-touch, team-based outreach model, which means we provide services to people in their homes or places of their choosing. We address social determinants by connecting folks to benefits, Medicaid, Medicare, SSI, so on, providing housing if necessary, and employment services. We have over 70 of these teams that do that, and we are in 5 counties, so it's possible that some of the counties you all represent, we are in. We're in Lake County, McHenry County, Kankakee, Cook, DuPage. We serve approximately 5,000 people via these outreach teams in the form of long-term supports. And then we touch about another 10,000 via our homeless outreach teams. Oops. I also want to talk a little bit about who we serve. And you'll see that, and I hope you can see this, we do serve people with high needs primarily. You'll see that 41% of our folks have a diagnosis of schizophrenia, 26% have a diagnosis of bipolar disorder, and this global assessment of functioning is a scale that is clinician rated and assesses people in terms of the extent to which their mental health symptoms interfere with life domains. And 44 to 33 is our range, and that range means that people need significant support in the community because their mental health symptoms, are indeed interfering with their ability to function in terms of school or work, social relationships, and so on. What isn't here is that 80% of the people we serve have 2 or more comorbid health conditions. So very complex health and social needs. Oops. Also important to mention in terms of what we do, and clearly important for today's discussion, is that we partner with 3 primary care clinics to integrate primary care and physical health services into our array of mental health services. It's all we refer to our clients as members, it's all member-driven, and a good high-level view of how we see this system working is that we have the member in the middle, we have our outreach teams and primary care partners working as a team with the social determinants as well, all trying to kind of wrap around and provide services that are going to allow people to live and flourish in the community. Let me just for a moment talk about integrated care, and I'm going to go back to that other slide, I think. Oops. So I don't know how many of you are familiar with integrated care, what that means. So, there are various definitions out there. We're talking about integrated care as it's defined by SAMHSA, the Substance Abuse and Mental Health Services Administration. They actually put it on a spectrum, with true or highest level integrated care being care that's provided by behavioral and primary health care team, and one electronic health record in one location. So basically, the systems are integrated. Now, of course, very few people, us included, meet that definition of integrated care, and so we do a series of workarounds in order to approximate as much integration as possible, because we know that integration and care coordination are really key to providing care to patients who have complex social and health needs. So we do not have shared records, electronic health records. Primary care clinic has Centricity. We have a record called Smart Care. And what we're going to talk about today is really kind of, as I said, nuts and bolts of how we went about working with our primary care partner to share data and for us to share data with them. A couple of caveats before we get started, because I have to say we are lucky. We sought out primary care partners who were willing to share data with us. We had worked with a primary care partner previously where it was not as important to them to do, and it became an untenable relationship, not just for that reason, but a lot of it was the lack of interest in sharing data. So what we're going to describe begins from a really good place. We entered into a contract with the partners, and we, as part of that contract, had a data sharing agreement. The other really lucky condition or circumstance for us is that we also have Medicaid claims data for many of our members, and we did that by having people sign releases of information for that data, and we're able to then use that data to really identify high users, which we're defining, by the way, as anyone who's had 2 or more ER hospital visits in a quarter, so 8 over the course of a year. And that data is something that, as we talk more, you'll see is very significant. It's not a data source, though, that we're going to spend a lot of time talking about. We are going to just talk about the primary care clinic data coming to us and us going to theirs. So at this point, I think I'll just hand it over to Isa to start that.
Thank you, Kristin. Am I going the right way? Okay, great. So I'm going to walk all of you through the process. As Kristin mentioned, this was a year-long process, and we're still very much in a development phase here. So what did we do first? Well, we actually convened an interagency committee that started to look at all of the data. This was already following the contracts and all of the data sharing agreements that we kind of went into. So we had clinical leaders from our behavioral health care side and leaders from the primary health care side, and also some IT folks. So we had some EHR, electronic health record developers, because we felt that was really necessary for our next step, which was mapping the data that we have. So this was a really collaborative process. We sat down and we kind of looked, what information do you guys have from the primary care side, and what information do we have that we can share with each other. And as part of our project, we focused a lot on our highest needs patients, so those high utilizers, those folks that we identified as those that use the ER or hospital 8 or more times during the year. So yes, our first activity was mapping the data, and once we decided, what data we have available that we wanted to share with each other, we needed to decide, well, what is the best way for us to go about and share this information? We had multiple iterations of this data sharing process. The simplest, which was us sending them raw Excel worksheets with our high utilizers and some information, and them sending us information about the primary healthcare indicators. And really the more sophisticated and kind of recent solution that we've been able to adopt is through the use of an integration engine. I don't know if everyone's familiar with what an integration engine is, but it is a middleware application that really transforms and routes and translates data and messages from one system to another. So I want to point out that we were only able to really go down this path of obtaining an integration engine because we did get a foundation grant to pursue this. These are some more costly solutions, so we wouldn't be able to achieve this without some funds to make it happen. And we're very much still in the development phases here to achieve this true integration, the highest integration level. As Kristin mentioned, we follow the SAMHSA definition, so we're kind of somewhere in the middle right now. And we do have some handouts that we'll pass out at the end of our presentation that kind of define the different levels of data, primary and behavioral health care data integration that you can take with you. So we're still in the development phase. Things aren't seamlessly kind of coming through from their health record into our health record. But for right now, what we've been able to achieve is that our data seamlessly goes into this integration engine. Their data goes into this integration engine. So we kind of removed the sending emails and having to communicate with somebody on that end, and we're able to export that data on our own from that system. So then in terms of the best reporting methods in identifying what would work really well for us, we did look a lot at different ways to store our data, analyze our data, and how we would want to report our data. And one lesson that we learned here very early on that's really critical at this stage is that you definitely want to have buy-in from your IT departments, especially if you are pursuing some of these high-tech solutions. So we kind of learned the hard way that if you don't have that buy-in or you don't have that expertise, well, that was fun looking at some of those really cool softwares that are out there. So we looked at data warehouses, we looked at analysis platforms such as Alteryx and even Tableau as a way to develop interactive dashboards, but all of those are really costly, especially on an enterprise level for an organization such as us, and we also didn't have the right IT kind of talents to be able to put all those in place at the moment. But if you are able to implement those, you have that IT buy-in and you have the funds to pursue them, highly recommend them. Really great solutions to data storage, analysis, and reporting. So that is all great, but we don't have that. So we had to go down the low-tech route, which worked just as well. So we learned. We did everything in Excel and Access, readily available to our organization. We still were able to perform a lot of the same sophisticated analyses, and we were able to develop some interactive dashboards in Excel. Before I move on, I do want to mention that if you do pursue a high-tech solution, Excel is still a really great resource. If you are just doing piloting or kind of you're in a feasibility stage, really great to kind of like test things out right there and not have to invest so much money into a higher tech solution because it is a long journey with those higher tech solutions. So I'm going to show you guys in a couple of minutes our interactive dashboard that we created in Excel. And this is also going to serve as the template for the reports that we're going to be creating using the data that we are able to export out of the integration engine. So pulling together those behavioral healthcare and primary healthcare indicators. So some of the primary healthcare indicators that we really want about our high needs patients are things like blood pressure, A1C levels, and what medications they're on, just to kind of name a few. And what we're going to be sharing with our primary healthcare partners from the behavioral health care side are things like housing status, employment, levels of functioning, things that they really don't have access to, and relate more to some of the social determinants of health. So as you can see, we're going to be sharing the data that the other doesn't have easily accessible. Oh, and we also have the Medicaid claims data that we receive from the state, and we get that on a more regular level than the primary healthcare partners, so we are integrating those numbers in there too, so that they can see the frequency of inpatient use for those high users. And you can, well, I'll show you in a minute, you can like drill down into the data in a variety of ways. So I'm gonna have to go over here now. All right, here's our low-tech solution. I don't know if anybody's ever had a chance to create things, but kind of the back end of it is just a lot of calculated fields and pivot tables and data slicers. So this is just a kind of a mock-up of one that we use to train our staff on. And I'll just walk you through some of the ways to operate the data. So it's like 12 months of data. It's available for 796 of our patients. You can see the total admissions, and then you break them down by year in hospital. What's really cool about this that there's kind of trends over time here, and we have some admission details, admissions by type. But what's really cool about these reports that we found that our clinical teams really like is that it's great to see this in kind of aggregate for the whole organization, but you really want to know what's going on with the people that you're working with on a team. So we do have slicers here, some buttons here that you can select a team. If I select, an ACT team, an assertive community treatment team, I can see I have 14 of my patients in here. They account for 46 admissions. So you can see people are going in more than once. And what's really cool about this is that we actually stratify the people by readmission and risk levels. So total readmissions within 30 days of the 46, 18, readmission rate of 39. And then you can see that this team in particular doesn't have any high risk members. So the majority of people are going in 1 to 3 times, and then a smaller group of 5 are going in 4 to 7 times. So this particular team doesn't have any of those high utilizers that are going in, but others do. And what's really cool, that we pulled in some data too from our electronic health record, but what's really cool about this is that towards the bottom, you actually get a list of people's names. So it's much more actionable that way. You can see right away who are the high-risk users. You can take that to a team meeting. You can put that data to use. So I'm not going to spend too much more time here. We just want to demonstrate, what we've been able to achieve. And then some of these other tabs here just have information that is available in the table. So a lot of stuff that is being pulled from our electronic health record. So we could have made this happen in a very sophisticated software. We couldn't afford it. Here's what we were able to create in Excel, and we found it to work really well and still visually pleasing and interactive for our staff. All right, so now we're moving on to report implementation and sharing. Showed you guys the low-tech solutions that we were able to adopt here. Just a couple of things about report implementation. So we have this product, what do we do with it next? So important part of making sure that the data is going to be used is through some appealing, visualization, something that is user-friendly for the most part, and timeliness. The reports need to be timely. And really what we also learned is that data sharing is great, but it's really only as good as the use to which you put it. So our end users, again, are kind of the RNs on the primary healthcare side and social workers within our behavioral healthcare agency. So primarily those are our end users, but within each of those organizations we also have senior level executives that are looking at these kind of just to get a bigger, broader picture and get kind of the health of the organization, like what's going on here with some of these individuals. So we're going to focus on really the latter group, our end users, in describing the process that we are going to be going through to implement these reports to get folks to start using them. And I want to point out that this adoption strategy that we're going to be using with our primary healthcare partners is one that we've actually used when we've introduced these Medicaid claims dashboards to our clinical teams at Threshold. So it's something that we found that works really well. And what we end up doing as a first step is really getting people in a room, opening up one of these things, and kind of just demonstrating what are the different aspects of the report, what data is presented, making sure that they understand what each of these indicators are, what is a readmission rate, how are those things calculated, what do all the buttons do, and how can you slice and dice the data. What I didn't show you guys is that one of the buttons, maybe you noticed, does allow you to just cut the data by risk level, so you can just go right away to high users and see that for an entire program or just a team, depending on who you are within or the organization. So we do go through that process, kind of the nuts and bolts. And then what we need to do is we need to determine with those end users, because remember, we're still not at that true integration where you open up a health record and this kind of dashboard pops up. So it is still in Excel. So we needed to decide, okay, once these reports are created on a monthly or quarterly basis by our dashboard creators, the data is being analyzed by our analysts, where is this information going to live? Where is it going? This might seem like a really trivial activity, deciding where are you going to put this? But we've learned that issues related to access and ease of use for staff can be a huge barrier to data use. So you want to make sure that you really address that right up front. And then also, as important as that is kind of determining the frequency of the information that you're going to be sharing and how you're going to be sharing that information. So we try to really identify like a data champion, someone in middle management that is going to be able to prompt the, for example, on the primary care healthcare side, this could be like the RN manager who gets the report, places it somewhere, and then informs the rest of the clinic staff, hey, we have a new report that is available. All right, kind of slack for time here, so I think that's it. Kristin.
Okay. Okay, so just a couple of takeaways before we finish. Again, don't need to wait for high-tech solutions. Low-tech are easier to implement, quicker to implement. And I think just also to say, I was in a panel yesterday hearing about some difficulties people have getting data, actionable data at the client level from the state. I think that that is a really legitimate concern, and I think that if it is in a system, it can be gotten out of that system. And secure email that we used initially in lieu of the integration, prior to the integration engine, worked beautifully. I don't know whether Isa mentioned that the email was a secure email, but I think that that is an easy, fairly easy solution if I was understanding the individual's concern yesterday. So I just wanted to add that. In the Q&A, we can talk more about how you might go about persuading partners to share data. We did have willing partners to begin with. We have in the past used reports that we had internally to share with partners to show them what was possible, and that will on occasion kind of hook an initial interest and begin the process of at least talking about sharing data. So if you have something internal to a department or internal to a provider, your own organization, that might be a useful thing to think about doing. So I'm going to stop here and let Isa just sum up data use.
Okay, so just some quick ways to overcome some of the tech or human barriers to data use. Making sure that you kind of reinforce as an organization your approach to being data driven. So we kind of hammer that in right away from the start to staff through the onboarding process. We discuss the triple aim of healthcare, population health, and really kind of try to drive home like we are an organization that uses data, and it's really important for you to understand your role in using the data. Demo some of the dashboards that I just showed you, kind of try to hook people right away like, wow, this is an organization that is using this. Like I don't feel like what I'm putting into an electronic health record is just a black hole and no one's looking at that. And also, we share stories from the field. So storytelling with data is something that we've recently started where we go and solicit things from some of our teams to see, well, how have you used data as a kind of point of departure for tailoring services to try to reduce reliance on the ER or to improve health outcomes. And another thing that's really important is to understand the literacy levels of the people that are using those reports. Those could be varied. Some people are more comfortable with data, some people are not. So really understanding that, because data literacy really ties into good data quality and in turn data use. So having poor kind of documentation standards really results in bad, unreliable data and often doesn't create a lot of buy-in with people. So be critical of your data. We do a lot of quality assurance and quality control activities to kind of spot check things and identify areas where there are opportunities to provide training or consultation to teams. And it is truly an iterative process, but also don't wait until your data is perfect. We've kind of learned, and we heard a little bit in yesterday's presentation too, even the state has gaps in their data, so if we all waited until things are perfect, we would be here for eternity. So you use what you have and try to kind of slowly improve things. And one solution that we've also kind of implemented was to kind of think about our workforce and the different levels that we have of people and how they will interact with the data. So a VP is going to be looking at data for a very different reason on these dashboards than somebody who is working on the ground with patients. So we came up with 3 different levels of interaction with the data. The most simplest being data viewers, kind of getting a high-level picture in the dashboard, just really seeing what is happening, taking kind of the temperature of the organizations. Then we have drillers. Those are people usually in middle management, so like a clinical team leader or a RN manager, and those are the people that are looking at like what happened and why did it happen. And then for us in particular, the largest percentage of our workforce are those clinical social workers working on the ground. So those are our knowledge workers. Those are the people that really take that information from those dashboards, really drill down to see what is happening, who are those individual patients that they're working with, and then they use their education and clinical expertise and the data as a way to kind of tailor services and interventions that they provide on the ground. So that is everything. Now we'll open it up to Q&A.
Well, I have a question regarding that then. I suspect that you've got your dashboard set up in a way that, let's say that you integrate care then for that particular member. I suspect that you can follow them out to actually see have we had decreased visits.
Oh yeah, 100%.
So it's kind of a perpetual
Definitely.
piece of
Yeah,
data.
that's what we're looking for. We don't have data to report on that yet, but that's the goal, is to reduce those inpatient stays.
Did you find you had quite a learning curve within your organization as far as data interpretation?
So senior level staff are pretty familiar with, I think it's true most places, financial dashboards, that and that higher level view. Yes, the on the ground clinical staff who are using data to tailor care or make mid-course corrections. That's an ongoing issue.
Yeah, so we do end up providing some technical support, training, or kind of embedded consultation at a team level.
Well, this is an opportunity for us now. We have questions now, seeing both approaches to the data collection. Does anyone have any additional questions from the healthcare setting or from the community setting in the integration that you were putting together with law enforcement and our service providers? I see the hand. Go right ahead.
I'm interested in the mechanism for distributing those reports. Is it correct that you'll just send out, share out the Excel files that include all the data and folks will have access to it at that point, or is there any possibility of making that available in a secure channel online?
Yeah, so right now what we're dealing with, which you may all know, is that clinicians really don't like to go to two different systems. So if it's not in their medical record to get them to go to another portal, which we could do, they're not going to do. So one of the ways in which we get buy-in for the reports is we ask people where they want these reports to reside and how they want to get them. Currently, our primary care partners, the RN nurse manager is going to receive the report via secure email, and she's going to put it on a shared drive that the advanced psychiatric nurses, practitioners, feel like they can then just, it'll be on their screen that they can click onto. So while we have the capacity to do that, that was not what they wanted. And the same for our teams. They will not do that. So we just have a shortcut.
Does anyone have any other questions? Can we give a round of applause to our